Hello, everyone. Good evening, all of you. Today, I'm here to discuss something which is one of the most commonest questions asked to me. People do ask me that what are the possibilities or the newer advances or the newer treatment protocols you would offer when you have a failed cycle. So many of the times, what happens is people only know of IVF as a retrieval of eggs and making embryos and putting them inside, and that has to stick with a certain percentage of success. And if that doesn't happen, you repeat the same process, take chances, and keep on doing it till maybe you reach success or where you decide you don't go ahead. But then there are certain things which are not always done in the first IVF cycle. So we have so many advances, we have so many things which we do when we have repeated IVF failures. Now, what has happened? So much of advances in science, technology, and this has definitely influenced. And our field of artificial reproductive technology is one of the first ones to witness so many advances in the scientific technology. So we, as you all know, is an assisted, an artificial reproductive technology, which is IVF and ICSI. So what happened around so many decades back, maybe 1978, 79, the first IVF babies were born in the US and India. And from then we have been changing, making so many changes. Initially, we were very happy with the fresh, and now we are moved to frozen, and again back. We have come back to a little bit of fresh embryo transfers. So, what happened over these years? Earlier, the success rate were only 10 to 20% to start with. The fresh embryo transfer successes were 40-50%. With the advances in technology, with the advances in science, betterment of the skill set, we have reached success rates of approximately 60 to 70 cumulatively in frozen embryo transfer cycles. So what has happened over these few decades, especially the last one decade, has witnessed so many of changes. The changes, if you look at from the injections, that is the improvement or the purification of the gonadotropin injections have become better. The stimulation protocols have evolved. The lab, the culture medias have become better over time. Sustainability of the culture media, the equipments, the sustainability. We used to have one big incubator. Now we have small scale systems where every embryo can be kept in a separate, small mini incubator type. We have benchtop. We have better humidified incubators. We have witnessing systems where everything is in place, that we know we are using the right dish for the right patient. So these all have evolved, making IVF more simpler day by day, yet less complicated. We evolved over time and we started understanding that there is a lot of research going on, and we have come so many things which tell us that this could be the most probable reason for failure. Now, if you go look at IVF, what we do first is we do a retrieval, we do embryos, and then we transplant back or implant back the embryos into the womb, and that's supposed to be giving a fertilization or a rate. But then what happens over time is there are certain reasons. Now, if you look at implant embryo, what do you understand from it is that the embryo could have not grown beyond your lab in the womb of the mother, or the implantation has occurred and it has slipped out, could leading to a biochemical or just not showing up on the blood test, so the body has rejected it. Or the endometrium, everything has been placed, but the endometrium was not very receptive. The genes of endometrium are not accepting or having a good crosstalk with the embryo, causing the implantation failure. So now going into the details of all these, one of the most important things which has been studied of late and which have been proven to have an effect on the embryo quality is the ROS activity, that is oxidative stress activity on the sperm, on the egg, has been proven, and this ROS activity has changed the genetics of the egg, the sperm, and then hence the embryo. So this epigenetic changes which have happened over the few years, thanks to our lifestyle, to the dietary habits we have, to the stress we have, the sleepless nights, the less activity, the dietary changes, so many things which we follow the world, keeping our cultures aside, is led to a lot of things. And this again has provoked more research, and it's become like we're trying to understand what could have been prevented. But coming back to it again, so what are the changes, what are the things we look into when some failures or unexplained infertility come, is go on a higher level of treatment. So what are the things? First, when the embryo or the first starting from the sperm, maybe the sperm has the ROS activity. So this leads to certain small fragmentation in the genetic structure, the helical genetic structure, just like a glass spiral staircase, which will have small breaks. And these breaks, when given the higher job of fertilizing an egg, forming an embryo, may not form an embryo properly, may form an embryo, may not implant, and if formed implant, it may abort. So these changes, epigenetic changes, or these whatever the loss or the gain of the genetic material leading to the increased DNA fragmentation index could be one of the reasons. And this, over the last, I would say, 7 to 8 years, have been being studied well, have been proven to have maybe an effect on the embryology, and especially shown to have an effect on the pregnancy losses. So how do we understand that? Is we understand, we try to measure the fragmentation index or the stress on the sperm. So this is, again, if it is there, now we are today understanding what could be the reason, what could be the probable reason, I mean, and what could be offered to nullify the effect to certain extent. So this is what happens is when you have a sperm sorter. So you have a technology like magnetic sorting, or there could be a piezoelectric sorting, or there could be a microfluidic sorting. So there are many types of sperm sorters. So these sorters separate the sperms into a better one, that is low DFI, and a higher DFI, and we use these low DFI sperms for ICSI. So ICSI, IMSI, all are the advanced technologies in IVF which are offered to failed cases. So this is one thing. The other thing is when you want to understand the genetic potential of the embryo. So we have the genetic testing. So if you say that you have 2 to 3 failed unexplained embryo transfers where we have noted a good endometrium, the hysteroscopy has been normal, the embryo was good, maybe a day 5 blastocyst, which was a good quality and still has not implanted. The second reason could be that there is been a genetic change in the embryo, and this genetic changes are found out by the genetic testing, that is embryo biopsy, which was earlier called as pre-genetic testing or pre-genetic screening. Now we have divided it into only testing for the numbers, that is aneuploidy, that is the total number of the chromosomes of the embryo, or we go into single gene disorders, which is PGTM, or structural changes, which is PGTSR. So when you have genetic problems in the family, suppose the marriage has been happening within relationships, uncle's child, or so many of the first, second, third degree consanguineous, there are a lot of genetic problems which are shared between the husband and the wife, and that goes double to the baby, and that could reflect as a genetic disorder to the child. So here we have a very advanced technology where we can take a biopsy of that embryo, that is a trophectoderm biopsy. We see for that single gene which is there in the father, in the mother, or in the family. We keep take those embryos out, discard them, and transfer only the embryos which don't carry this particular genetic mutation. So this again helps us give the a couple who've been having a lot of pregnancy losses with genetic abnormalities, we can offer them to have we offer them this technique, advanced technology in IVF, to give them a healthy child. So with this is one thing, and other is, maybe that as the age advances, there are a lot of aneuploid, that is a not good embryo. So we screen them with genetic screening. So what we do is we put all the embryos the market. Studies and trials have to be done, but then yeah, it is non-invasive. So we just take the spent culture media. The embryo always survives in a medium, and this media is sent for it will shed its cell into the smaller cells into the media, and these cells are representative of the entire embryo. So these cells are cultured, and we try to understand the genetic problems which the embryo may have, and not doing a invasive biopsy of the embryo. So keeping the embryo safe, we can take a chance and do a non-invasive testing. So this is another way we try to help the failed cases. The other thing is the receptivity of the endometrium. So the endometrium may look very good, hysteroscope is good, the blood flow is good, the doctor says everything is good, we don't know what is the reason, but there could be some receptivity which is not matching to the embryo. The embryo and the uh, endometrium have to have a proper day of progesteronization. They should match the day of the hormone change from the estrogen to the progesterone. And this change may go a little advanced, that is post or pre-receptive stage in the endometrium. And this test of receptivity assay may help us, though the studies have been very equivocal, may not find a difference. But yes, this could be one of the tests a patient could ask us, and we could offer them when there are, 3 4 transfers failed without any reason. And sometimes yes, the scratch of the era, or the maybe the entire cycle being replicated again, better growth of the endometrium does help the next cycle to have implantation and a successful pregnancy. Now, when these receptivity genes were being tested, there was something, a newer study would talk about the microbiome. So every one of us know that there's something called as a good bacteria, bad bacteria, I would not say. A good bacteria is something which has to be there in our body. It has to be there in our gut, which helps us having digestion. It has to be there in a woman's vaginal flora, which helps us her keep healthier reproductive, better reproductive health, have good pregnancies, less abortion rates. And these normal bacteria, when they're invaded by the not good bacteria, the change in the acidic pH of the vaginal fluid would lead to implantation failures, to infertility, to pregnancy losses. So now there have been a lot of studies which we are doing on the microbiology of the flora of the vaginal or the endometrium, and there have been found that many of these floras are not, the commensals are not good for implantation. So we change them. We try to work with the antibiotics, with the probiotics, help them, and it has been shown quite good results till date to have, better implantation and pregnancy rates. So there are all, these are the highest tests, though it comes with a cost. But yes, there's some of them help us give a woman who's have 3 4 failed embryo transfers a successful implantation and pregnancy. Now, after this, there's something called as immunity of the body. So, the body, everything is good, but the body says, I don't want pregnancy, it rejects. So, that's called as an autoimmunity of the body. So, autoimmunity leads to pregnancy losses, a very, very known phenomenon where we say that APLA or many other antibodies would lead to a pregnancy loss, especially in the first trimester, lead to preeclampsia, that is higher blood pressure in the second half of the third trimester of the pregnancy, causing baby growth restriction, a decrease in the fluid, and many placental dysfunctions. So this, when you inspect stability pre this to infertility level, would start by rejecting the embryo. So they would change the body's immune system. Ideally, it is before the pregnancy, it has to be a pro-inflammatory, then it has to be anti-inflammatory. So inflammatory change doesn't happen in the woman's body. This would lead to a implantation or per se infertility before an IVF, and then if pregnant, a pregnancy loss. So what we do is we try to understand the immunology of a woman. There are a lot of tests we run, like HLA testing, the natural killer cells, and then these tests again we try to give them a little immunomodulation in by either immunoglobulins, or we work on their there's something called as an LIT, that is we give the transfusion of these lymphocytes, which would change or alter her immunity. So what happens then is the baby, the body gets acceptance, accepts that embryo, and then I mean, embryo is always an outsider to the uterus, and then the pregnancy continues. So these are few things, and there are many many things which are in the studies. Like we have the spindle transfers, we have maybe in future womb. So a couple undergoes an IVF, oocyte retrieval, embryo formation, and then the embryo is transferred into an artificial womb where we may not need surrogacies in future. So these are all the advances we're looking at. But at present, I agree with, in spite of so many advances, we have reached a success rate almost double of what it was 3 decades back. But still, yes, wherever required, I would say wherever indicated, wherever required, we have to go ahead, use the technology, and try to understand what is the cause, could be the probable cause, try to treat it as much as possible. And science is always there, advancing, always there to help us out. with the newer technologies for people, especially the indicated needy childless couples. We've seen so many things, helping us out with the newer technologies coming up. And apart from that, we have a lot of changes in our routine practices, that the preparation in the sperm preparations, the identification, the analysis, and the retrieval techniques. We have better machines. We have so many better the 3D visualization. The newer 3D or the 4D ultrasounds have almost changed the entire endoscopy of the uterus. So we have higher end laparoscopy and hysteroscopic equipments where we can go visualize. Maybe around 4 decades back, all surgeries were done by open techniques, but now we have endoscopies. So we go with small cameras inside. the hysteroscopic the hysteroscopic the diameter is like 2.9, maybe the smaller one is still coming, and the entire bigger surgeries of the uterine pathologies are done with this. So there are so many advances which we have and we offer to the patients. And I think science will keep on moving. We'll have more and more to learn and offer to our patients here, so that we can help them get pregnant faster. And I think, with this, I think I would open up my session for any questions. So I think a few questions here. There's one question which is asking me what is the ovulation time. It depends from the cycle length. That uh, Usually a woman ovulates in the exactly in the mid cycles, like 14th day if she has a regular 28 to 30 day cycle. So we keep 3 4 days here and there to tell them the fertile window. But it depends on the woman's cycle length. That her ovulation is usually 14 days before to her expected menstrual cycle. The success rate and the complication of IVF. See, the IVF is an artificial procedure. Maybe I'm an IVF specialist, but still I understand it's an artificial procedure. And the complications of IVF, as such, there are no major complications except that you have to take the side effects. I would say is to take a lot of injections, 10 to 12 days. The newer injections are subcute, and you don't feel so much of pain. They're pen devices. What we use in our hospital here are, many of my patients say it's quite painless. So these ones are the side effects. Going through the emotional mental trauma would be more a side effect of IVF rather than a complication. The complications of IVF, unknown, few of them like hyperstimulation, where many eggs grow, and if not taken care at the proper time, may end up in a little morbidity for a woman. And there could be, some difficult cases where endometriosis or frozen pelvises or previous infections, where there could be injury to the vessels or the ovarian vessels, or some adnexal structures there, and that could lead to bleeding or maybe sometimes infection. But these are too rare to be observed in a day-to-day practice. And now there's one question about, how actually is PRP beneficial? So PRP is again one of the newer technologies which we offer for ovarian low ovarian reserves. So this is the stem cell or the PRP. It comes from the very initial precursor cells which are put into the ovary, the endometrium, and the endometrium, that's the lining of the uterus, and these grow, and then these form a better gamete or a better endometrial cells. Now, because the endometrial cell is a regenerative tissue, it's usually what we see is that these regenerative tissues are benefited more. So PRP has worked in places where the regeneration is more. Some of them have used it in, especially in the joints and the endometrium. We have found very good results, especially if there is no major damage to the endometrium. The basal layer is good. I've seen wonderful results with PRP in endometrium and ovarian reserves also. If you, I always say there is a slope of the fall. So if in the slope, if you're too down and you try to do in your menopause, you try to revert things back, may not be possible. But in early slope, early fall, the PRP stem cell definitely gives you maybe one good quality egg, would help you to get pregnant. But in endometrium, definitely has a wonderful response which I've seen. And one second. And there's one more question. Uh, After multiple abnormal fetuses, how do we plan? So this is what I answered in one of in the talk now, is that you have to first understand the genetic testing has to be done for the parents, that is both the couple, and then if the genetic testing, that is a comprehensive carrier screening, or the entire genomic studies have been done, and this sequencing finds out to be some genetic common in both of them, this genetic testing can be put on forward to the IVF. We test the embryos before putting them, and then if there is an abnormal embryo, that is discarded. The good embryo is kept. And majority of the time, abnormal fetuses would have some syndrome, so they will diagnose the syndrome. So every abnormal fetus, it's recommended that and advised that you get your abnormal fetus tested properly for genetic testing. Try to understand what is the genomic syndrome. If this genomic syndrome is sporadic, by chance, it's your bad luck. But if this genomic syndrome is some part of genetic familial genetic syndromes, then it needs to be evaluated. Go for an IVF, go for PGTM, and then you may have a successful baby, any healthy baby. So, what is the difference between A and M? A is where we take care, the number of chromosomes you have. So, those number of chromosomes are tested. So, the total number of the chromosomes have to be good. So, 46 means 46. If you have one extra, so that's a trisomy, or two. So, or one less, that's a monosomy. So, these testing is called as euploidy and aneuploidy. So, aneuploidy is one set or one chromosome pair is missing. So this is tested, is just a routine screening to test a number, is PGTA. PGTM is what I told, one of the questions here, is when you test for a single gene disorder. That is, you see that this gene is abnormal, this small gene in that segment of the chromosome is abnormal, that particular gene is tested, that embryo which is positive for that is kept aside. But when we do a genetic testing on embryos for PGTM, we do PGT alongside, so that we don't transfer an extra embryo or an abnormal embryo, extra chromosomal abnormal embryo to the couple. So, how many days of abstinence is required to give DFI? So, see, the DFI concept is it is influenced by a lot of things. The DFI is the DNA fragmentation, smoking, alcohol, lifestyle disorder, stress, sleep pattern disturbances. These are the commonest things which we keep telling patients. The age and medical surgical disorders, presence of varicocele, or could be many things again that could lead to a high DFI. Abstinence is one of the most proven factor for DFI. So if you have long abstinence, you will have a DNA. It's a stale sperm, you would say, and a higher DFI would be there. So this abstinence method we fall in many of the times we follow in high DFI patients. So we tell them to have consecutive ejaculate every alternate day or every day to reduce the DFI, and that DFI, that sperm, we use it for the ICSI. So when we give, we test a DFI, we test like how we do an IVF. So at least 1 to 2 days gap I give to test for DFI, because if the with abstinence, more abstinence, the DFI is going to be high. But even if with less abstinence, if the DFI is high, that means that this could be one of the reasons why embryos are not forming well, or there's a failure in the lab. You have 20 oocytes, good quality. At the end of 3 days, you're not left with any embryos, or day 5. That could be that this could be one of the reason that the sperm has not been able to give a good genetic potential to the embryo. So this is about DFI. After how many failures should be shifted to IVF procedure? See, IVF is a last resort, always. I always tell my patients, I always tell my students that infertility is different and IVF is just a part of infertility. So when you come to us, we evaluate you. We start with basic ovulation induction, provided all your parameters, age, everything is in place. You can go ahead with 5 to 6 cycles of normal ovulation induction, tubal test being done in between, normal tubal test, try naturally, all going good. You can try 5 to 6 cycles ovulation induction, 5 to 6 cycles of IUI, and in spite of that, if you don't have a reason or unexplained, then we step up to IVF. But where we have a direct IVF is when there is a tubal block, the eggs have been very less, the sperm count have been less, there's an altered structure, anatomy, age is more, or you're going for genetic testing, you want to segment fertility preservation. So these are the ones which have direct indication for IVF. There are many more like that. So so these ones you go directly. But if there is no reason, you just married, tried for an year or two, younger age, you can try for a year or two. Come to us, evaluate yourself, and then try ovulation induction. whatever been suggested by your doctors. Is transferring in natural cycle better than IVF cycle? Yeah, I mean, depends. That depends upon your doctor, what she understands is a problem with you. So natural cycle is always better. Nature is always better than artificial. That is my dictum of my practice. So wherever possible, yes, but it's not always possible to have a natural cycle, because majority of the patients who are infertility would have some issues either with ovulation, synchrony, endometrial thickness, something either egg grows fast, endometrium doesn't, endometrium goes fast, egg doesn't. So in case the natural cycle is too good and you are doing maybe an IVF in a tubal factor, in a male mild male factor, then yes, the natural cycle would definitely be better. Where your eggs are not growing, that's PCOD category, or you have no eggs. So that cases natural cycle may not work. So that depends upon your doctor. I think she would be the best one to suggest you which type of transfer would be better. But yes, natural given a chance, if you could have a natural cycle, then I think we are shifting. So as I told you earlier it was all fresh cycles, fresh IVF cycles. Then we came to frozen embryo transfer cycles. Success rates have been increasing. Now from frozen, we are coming back to modified natural or natural cycle. It's basically not natural totally, it's a modified natural. So modified natural or stimulated cycles for embryo transfer, keeping in mind that the egg or the corpus luteum, which is has released an egg, would be the best uh, thing to give you hormones for the baby. What we artificially give you hormones for the pregnancy, the same hormones, we mimic the corpus luteum, but nowhere we can actually replace the corpus luteum. So corpus luteum secretes so many hormones, we replace few of them. So if there is a corpus luteum in an ovary, that would always be the best for a woman to have a pregnancy. So what is the reliability of non-invasive methods? So non-invasive methods for genetic testing, I presume, is reliable. It's very new in the market. We've been trying to work it out with compare. There have been few studies which have compared and quite reliable. So if you go back few years back, the non-invasive testing of blood came for the antenatal screening, that is first trimester screening. It may not be as good as amniocentesis, but yes, in certain cases, the fetal medicine specialists do recommend it. So, such ways, non invasive testing can be tried. It's no harm to the embryo except the cost. So, in case that we can look at it, that yeah, in case we put the embryos, we get something abnormal, we can try not putting that embryo in something is normal. The normalcy chances would be definitely more. If we can get a normal chance, then the embryo should be euploid. But if there is mosaic, or they're not able to understand the genetic material, then maybe we can shift up to the genetic testing, that is invasive genetic testing. Is stem cell therapy useful for increasing AMH? To a certain extent, if you take the treatment a little early, the AMH is secreted by the pre-antral or antral follicles just before they become dominant. So these small follicles, this batch, if they get rejuvenated by stem cells, they may secrete better AMH. So AMH is basically a hormone which is secreted by ovary, and this tells us the number. So if there is this cohort, this much AMH will be secreted, and that's how we measure it. So AMH may improve if the cohort improves, and the cohort may get rejuvenated if you have done a PRP stem cell in a very early stage of the ovarian fall. Which embryo is recommended? The same day 3 forms day 5. So if there's a good day 3 embryo, it will definitely form a good day 5 embryo, provided the culture media is good. So in present scenario, majority of the labs across the globe have a very good culture media. So if there is a good culture medium, we have a good blastocyst rate. So if I put some, say 10 embryos, if we can get 6 blastocysts, it's like, wow, that's too good. 5 to 6 blastocysts. So, but identifying which embryo would become a blast is a little crucial step on day 3. So sometimes we have too good embryo. And if the genetically normal, it usually 80%, 90% our embryologists do predict that this would form a blast, and it does, but the 20% times you can't predict, and that could be deselected or selection of whatever comes out of that 10 day 3 embryos. You have so many day 5s, and so you're not putting those day 3s into the body, where which would not form a day 5. So you've selected till day 5, but beyond that, again, it is has to happen by its own. And genetic growth, or the change is what has to happen. The genomic of the embryo has developed by day 5. So that is why day 5 if possible, is preferred, but it's not that always it's day 5. Sometimes the day 3 embryos don't reach day 5 in the lab, artificial culture medium, but they reach a day 5 in the womb. And I've seen so many patients with less eggs where they have 1 or 2 day 3, which will not go to day 5, an average quality of embryo giving as a pregnancy. So it depends upon your clinician's decision whether this embryo may go till day 5, and if it may not go till day 5, she may offer you a day 3 embryo transfer, and that day 3 may click with the newer study talking about 20 to 30% success rates, rather than advancing the embryo to day 5 and having no embryo on day 5. So this is a very tricky decision, which I think your clinician and embryologist would definitely think, a lot in your terms and decide. But actually, if you ask, a good embryo on day 3 or a day 5 would not make much difference. In our practice, we've not seen much difference. But yes, there are certain set of patients where we prefer to do day 5 only, where you can have the advantage being you can transfer only single genetically tested embryo. Some people we prefer to do only day 3. Some of them we give a choice. So there are so many day 3 embryos. I would go with day 5, and we would prefer to put a day 5 embryo. What is the age of the mother is considered risky? Uh, Earlier, we would say 40 as advanced maternal age, but I think we should cut off to 35 now. And I think now, the age, as the generation is moving ahead, the egg reserves have started falling at 30. So 30, 32, we see women with low MH, and hence I think uh, it's after before 30, you better get pregnant, try to get pregnant, or better finish with your pregnancy before the age of 30. And if not, meet your doctors, understand your reserves, and after 30, keep monitoring yourself to have a pregnancy. And if you're looking at pregnancy very later, which we would not advise, but due to personal reasons, family reasons, you have an option of fertility preservation. Again, a newer advance, which is like we can preserve your embryos biological age or a genetic age. So you have a pickup. I have so many patients who at 30, 32 have IVFs, had babies, come back to me at 37, 38 to have a 32, the age, the oocyte or the embryo age when she was 32. So that embryo would be definitely better than the embryo she would have at 38. So that's one advantage of fertility preservation, and especially in cancer patients where they run faster with the ovarian reserve fall. I think that's again an indication to go for egg reserve, I mean, fertility preservation. So to keep their fertility or the embryos preserved with us and transfer whenever they want. So, karyotyping is again a genetic testing. That is the analysis of all the chromosomes. That is, you analyze the number of chromosomes. Ideally, what we say, the 23 pairs. Is it really necessary to take embryo transfer take post embryo transfer? If yes, how many days is it necessary to take post embryo transfer? I didn't get this question. Is hysteroscopy a cleaning procedure? Same the reason behind? Yes. Yes, I mean it depends on what your doctor means, but yes, screening procedure in layman term is nothing but hysteroscopy. So, hysteroscopy can be operative diagnostic. So the diagnostic hysteroscopy is when the implantation is not happening. Some polyps are missed, but nowadays with the 3D scans and all, the missing of the polyps is very less. So we can see something like a chronic endometritis, that is old infection. Maybe there is a small or an edema you can't see when you're putting the embryo transfer catheters, it is getting stuck there, or the endometrium is very hyperplastic. There are patches of good endometrium. So these are small things we see. Scanty endometrium, the basal layer is not good, fibrosis is there. These all things are diagnosed in diagnostic, and if there's something comes up, we do the surgery and we try to do the therapeutic work with it. And what happens, as you asked, this cleaning procedure, Maitri, is that when you wash, it's just like cleaning your house. So when you wash the uterus, all that older tissues, it all comes out. And the next majority of my patients, if they're listening to me, would witness that post hysteroscopy, the cycles have been too good. So every woman I asked, and that's a smile on their face, takes a smile on my face when they say, "Madam, this time the cycles were too good." So for women who have thin endometrium, we do the cleaning. The same time PRP procedures are done, and the next cycle has a very good bleed. And this is, I think, we understand that this is what a cleaning hysteroscopy, we call it as distension hysteroscopy. We just put saline for some time and just do a scratch and come out. So this is helps for implantation definitely. So I think I've answered these two questions together. Chances of damage while doing a genetic testing. Yeah, this is one of the smaller things which is always there, a fear in the embryologist's mind that if what happens if the needle damages the embryo. What happens in embryo is one side of the embryo, there's a small ICM, that's inner cell mass, which helps them to form a baby. And the other part is which helps them to attach to the uterine wall, invade, and form a baby, attach the pregnancy there. So we do a testing of this trophectoderm biopsy, which again, as I said earlier, is a entire it represents the entire genetic material. Maybe that trophectoderm may give you a false positive or a false negative report also, because that's just a representative of the main ICM, which is going to form the fetus or the embryo, which is going to implant and form a fetus later. So but the damage is always very less. Nowadays the skill set of the embryologists have become so better that the damage is too less. I've not seen till now with my embryologist having any damage of the embryos, but I would say in unskilled hands definitely the damage would be there. Is it really necessary to take bed rest? Okay, I get now. No, no, bed rest is not required. I would say that the body circulation is very important post embryo transfer. We don't restrict any bed rest. I especially give a letter to my patients saying no bed rest, please. uh, you go do your routine activity. Don't get fall sick. Don't go out of your way. Don't do the activities you were not doing before. And routine activities, whatever you're doing before, excuse me, is advocated and advised in post embryo transfer. Excuse me. First beta HCG value 17. Yes, Archana, I think this is what I told you last, is that this is called as missed abortion, and this is 60-70% of the times genetic of the embryo. You may have a normal genetic type testing. Your husband may have a normal genetic testing, but your baby, which is formed by the mixing of the two, may not be a good embryo. And 60-70% or 50-60% of the times is a genetic reason for the embryo missed abortion. Another important reason for missed abortion is autoimmunity. So the baby is being killed by an antibody. So this is one of the reasons that missed abortions we are more worried, because these are known to happen. The non-viables are usually genetic. We presume it will not happen next time. The blighted ovums, again, if there is a luteal phase defect, we can correct it. But missed abortions, we do a genetic testing, we recommend it, and we do your autoimmune panels profiles, and we put you on higher level of treatment in your pregnancy. So as soon as you become pregnant next time, you have to go and meet your doctor. How useful is sperm sorter? Previous failures, yes. As I discussed earlier, sperm DFI, one of the commonest indications, and it would be that when we sort out and take a lower DFI sperm, it would be easier to have a better embryology. We have seen cases with totally 100% failed embryology using sperm sorters, changing the protocols for the women, getting good number of embryos and getting them pregnant. So, what are the chances of pregnancy with embryo glue? Yes, glue is something which is new in the market. Add-ons. So, I was again going to discuss about add-ons. Was that there are certain called as assisted hatching. We don't know how much it would help, but in certain cases, they may be helpful, especially failed cases. We've seen that yes, maybe the zona is thick, the embryo is not able to hatch. So, assisted hatching and glue are the add-ons we offer. Now, the glue is something like it's something which is a molecule which helps the embryo to stabilize and may help. It's not the exact gum what you call. It is just a molecule which helps the embryo to stabilize, hold on to the uterus and implant. Microbiome testing I recommend in failed cases where embryo transfers have failed, undiagnosed, unexplained implantation failures. Microbiome testing has helped us, and we're doing it quite routinely. At least we're offering it quite routinely. Does all women with endometriosis? Not at all. Endometriosis, minimal, mild endometriosis, post laparoscopy conception rates we have seen very good. Now, so many of them, this clear the myth that if you do a diagnostic laparoscopy For so many fertile women, you would find few of them having surface endometriosis. So it's not that you have to radically treat endometriosis. You have to 100% do an IVF for endometriosis, mild endometriosis, minimal endometriosis, do conceive. But the thing is that the treatment should be faster, because every cycle of ovulation increases a risk of recurrence of disease or risk of increase in the endometriosis. If there is a small endometrioma, then if she conceives naturally, it would be easier for her. But if the disease is symptomatic, the disease has been recommended, there are certain indications for surgery, that especially most of them is symptomatic, or clinicians want it because of certain reasons for IVF, then surgery is recommended. And IVF post surgery for mild minimal case is not recommended. We can try IUI cycles, natural cycles, few. It's not that you keep on trying, because the disease would recur and again you would end up again in a resurgery because of symptoms. So, endometriosis, the treatment protocols are different, and please visit your doctor if you have endometriosis, because the fertility is definitely affected with endometriosis. What do you recommend higher level of treatments? It's all after failed cases. We recover higher level of treatment in ART. It's, I always tell, it's the first step is just basic trying, second step is surgical, IUI and all. That's level 2. Level 3 is ART IVF. In the level 3 also there is higher level. We all recommend after one to two transfer failures, because in one cycle of ovum pickup, if you have 2 to 3 sets, you can try 2 sets. Doesn't work, maybe the second pickup cycle you could go for a higher level of testing. What are the factors affecting DFI? I think I've already told many factors: lifestyle, medical surgical disorders, surgeries in the past, aging, smoking, alcohol, varicocele, the use of laptops on your laps, increased scrotal temperatures, stress, so many things. Obesity is one of the major causes, and unhealthy dietary habits, even your cholesterols, if your lipid profiles are abnormal, they're known to cause a higher DFI. So there are many things, infections, recurrent infections. COVID also could have caused a high DFI. We are doing a study of DFI, and we found many factors in our routine do affect. We find a higher DFI abnormalities, embryological abnormalities in the urban class compared to the rural. So that, I think, that gives your answer of what lifestyle matters. How many days do you take? 4 to 6 weeks for a genetic testing. Everywhere else I've been told for 3 blastocysts. I would not recommend 3 blastocysts, because we, being a Sweden based company, we recommend single embryo transfers with a success rate of 4. But yes, because it's not possible to do genetic testing in India for all, we recommend sometimes 2 blastocysts. Especially failed cases, we recommend 2, 3, and never put 3 blastocysts. It's not recommended. It's not recommended by our company. It's not recommended by the law of India now, and it's, I think, not recommended by science also. What are the factors? What are all the factors taken before embryo transfer? Embryo transfer, before that, we look into endometrium, the blood flow, a good endometrium. So sometimes I think my patients would agree, many of them, that I've taken six months, sometimes 8 months for that one lovely endometrium, and have transferred after that and they become pregnant. So I think it's patience with the embryo transfer, basically, for both. Clinicians may have, the patient should show a lot of patience to go for an embryo transfer. There should be no hurry for an embryo transfer from both the ends. Pregnancy is 45 age is able to get a pregnancy test. 45 in India is a little difficult to have a self good healthy pregnancy. Not that it is not. Depends upon your genetics. But yes, if you're going at 45, you would be recommended a genetic testing before you have an embryo transfer. Fresh and frozen. I told the evolution started with fresh, initially came to frozen. Again, it has come back to fresh. But we have a very good result on frozen embryo transfers. So there is no, hurry to do. In case there is hyperstimulation, in case there is endometriosis, in case there is pooling of embryos, genetic testing for embryos, fertility preservation, there is no fresh embryo transfer. But wherever possible, normal responders are the people who give our book number of embryos, 15 oocytes, 10 to 15 oocytes have 7, 8 embryos. We do one embryo day 5 fresh transfer. The disadvantage of fresh is genetically testing cannot be done. The corpus luteum, is a little difficult. The pain may be there, hyperstimulation may be there. The pregnancy chances may be a little lesser than frozen, but the biggest advantage of fresh is it mimics natural. So if you have a fresh transfer, the clinicians are less worried, except the little risk in preterm, but otherwise hypertension risk, which is given by frozen embryo, the IUGR risk, which is given by frozen embryo, the increased risk of venous thrombosis with estrogens on frozen embryo transfer is far, 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 or almost, I would say, very, very less compared to fresh compared to frozen. So, given a time, fresh embryo transfer, especially in the present era, is beneficial. We do a lot of fresh transfers because our recommendations come from Sweden, which believe in fresh transfer. So, we have come back to fresh transfer from a year or so, more than a year, I would say. We're finding very good results. Now, when you compare the fresh transfer when we started our practice 20 years back and now, is that time the labs were not so advanced. With this advanced technology, fresh is indeed giving wonderful results, but the selection for fresh has to be very good. So if the selection for fresh category of embryo transfer is there good, and if you do a proper case based fresh transfer, the results are very good. What is the care to be taken post embryo transfer for successful implantation? You have to take a good hydration, good food. Most important is stress free. Take very less stress. Okay, don't worry. It will work. Especially if you have given your best, the success rate is 60. You imagine 4 decades back, people were talking 20-30% success. People were okay then. They used to accept. Now, when we talk 60% success, patients don't accept. So, what you need is patience, relax, good food, good water, sleep, and take all the medications on time, because frozen embryo transfer, the entire pregnancy is on the hormone treatment. So, it's very important that they don't miss your hormone, the treatment. The medicines have to go on time. Any treatment which will help recurrent implantation failure. I think I've told so many things, Vishal, already. You have genetic testing of the embryo, endometrium, autoimmunity testing, hysteroscopies for failed cases. May try protocol change, and it works sometimes. Maybe you need to get a proper evaluation of the microbiomes, a DFI test maybe, and then try. Usually, I recommend not more than 4 to 6, 5 to 6 embryo transfers at the max. But somewhere we start evaluation after 2 embryo transfers failed. But there is some limit we have to stop. Role of immunotherapy is very good in repeated abortions. It's one of the known therapies we give for recurrent pregnancy losses. Lot of studies, and it is definitely very beneficial. What is laser hatching? Laser hatching is now, if you look at, you just imagine a eggshell cracking. So when you have an eggshell, that one area is the weakest point where the hatching happens. But in some of the embryos, which may come from an endometriotic ovary or an unexplained category, where the cover, that is the zona of the egg, is too strong, then these women, the egg may not fertilize by IVF also. So natural it will not fertilize, and IVF again is what the conventional IVF is, just put the sperm and the egg together. So what happens is the egg penetrates through the chemical reaction, acrosomal reaction. It puts its genetic material inside. It forms embryo, and could be the weaker zone. I don't know, but that is the place where it hatches. Sometimes this zona is very thick, and this gets pierced by our ICSI needle. We put the sperm inside, so we cause the ICSI causes the fertilization. After the ICSI, the fertilization happens. But the same egg, if it has a thick zona, it would not, the embryo would not hatch. So sometimes there is an restriction in the growth. So what we do is we just put laser hatching. We put it in two places where there is a recurrent implantation with thick zona. Frozen embryo transfers, frozen embryos also, when they are thawed, they have hardened zona. So sometimes the transfers are, take time, or I mean, they may not have a good hatching. So laser shots are put in recurrent failures where everything is good. And the third, we use laser hatching is for genetic testing. So we hatch, we put the lasers, and from that zone, we take the embryo cells for testing. Embryo transfer under anesthesia, yes, of course, we can do it under anesthesia, Sujana, but I would not recommend anesthesia. Let the natural process be as natural as possible. The problem is that there are no more studies that anesthesia would cause any problem. But as such, anesthesia is not recommended when it is not needed. And embryo transfer is such a gentle, delicate procedure. Get it done by a very good hand. Usually, I don't do under anesthesias. I don't know. My patients should agree with me that I usually discourage anesthesia. We have many other things which we replace in the place of anesthesia. So you can do it unless and until. But if you've undergone so many scans, if you've undergone so many IUIs and an embryo transfer and taken that discomfort, embryo transfer is absolutely no discomfort. So there are many things now that we give you as a pre-medication in IVF that reduces your anxiety, reduces your pain, and you are made very comfortable. Especially my staff in Medicover is very takes care. In fact, I too take care that we are very gentle, very good with the embryo transfer time, so that the patient doesn't feel very nervous. She's very good on the table, and none of my patients ask for anesthesia. When do you recommend ERA? Very many failed cycles where you have no answer. I've actually, if you ask me, I don't believe much in ERA. But yes, I've seen few of them. When the patients come and ask me, I tell them that it's it's basically the IVF is a soil and seed theory. So sometimes you just give a medical washout. You prepare the embryo patient for an embryo transfer, give good estrogens, good progesterone, make an endometrium, take the testing, and do an receptivity testing. And then, if it comes out to be receptive, you transfer the same protocol again, and the patient gets pregnant if it is receptive. That means that previously all the tests, all the embryo transfers you've done was also receptive. Time the embryo out. So these are many I don't say I'm yet to find in my era testing yet, but I've seen many cases outside which companies pre and post receptive. So it's basically the proper progesteronization is very required when you do embryo transfer. That could be the skill set of the clinician also, so that when to start the progesterone and how to go about which patient would need how much of progesterone, when to exactly start. And sometimes there could be a genetic abnormality that we have to understand, and there ERA may help. That maybe some endometriums are not at all receptive, but I'm yet to get a non-receptive in my own practice. Pre and post also have not seen yet, but I think I do it when I offer it to my patients. But if they ask me, I do an ERA. Even the first ET, Mamta, how many days the embryo? Implantation, if it's a day 5, it's just the next day, that that you put the day 5 embryo, it hatches and it has to implant. In few hours, we sometimes put a hatching embryo. I tell my patient, this is hatching, so it's going to go again, get attached, because it will have those sticky substances which will attach to the embryo. And in 2 days, it will start invading, and in a day or 14th day or 15th day, by day 7, it would completely invade and implant. And you would know after 10 to 12 days of implantation, so approximately 12 days of embryo transfer to 15 days, you would know the result. Hey, madam, first embryo transfer fails. What is the next process? Now it depends upon what the reason could be for the first embryo transfer. First, fresh. I think fresh you go with frozen, Rajita. Don't worry. Fresh is always there as a backup plan for us, because if it is good, we put a fresh, thinking that take advantage of the corpus luteum being there. But if it fails, the frozen always will give you better results. We will do hysteroscopy, cleaning, as well as distension hysteroscopy. We'll do a biopsy, understand what's there, and then change the protocols. HRT protocols are different. The minimum modified natural cycle protocols are different. And then you can try with the frozen embryo. It should work for you. uh, IVF, I would not say that's no side effects. Side effects are always there. Everything which has an effect will have a side effect. You want something, even pregnancy has its own side effect. I agree, artificial technology should be used at its minimum. I think end of the day, I would say that don't rush up to artificial technology just because you are want to have a baby immediately. Everything has its own effect, own side effect. The side effects are quite a number, but the percentages are not so high that these processes have to be abandoned. Majority of the times, as I discussed, hyperstimulation is one of the commonest side effect of IVF. But from last few years, we find a OHSS free clinic Earlier in the beginning of our practice, we've seen a lot of women having hyperstimulation free fluid admissions into ICU. But nowadays, because of the frozen embryo transfer, the trigger being changed, and better ways to curb down the antagonist have come from a decade. We are using antagonist cycles. The OHSS has been less. The other complications are too less to be spoken about. And the pregnancy in frozen embryo transfer is an artificial cycle pregnancy, so you have to be a little more careful. The risk of blood pressures may be little more than the natural. Twinning again is the biggest complication effect of IVF, and hence our team in Medicover and across the globe look at transferring single embryo transfers, finding at good as good results as the double embryo transfers. So we believe in having healthy pregnancy and a healthy take-home baby. So I think with this, I don't think there are any more questions. But I always tell my patients, choose the right place, go to qualified doctors, go to good hospitals, and take proper treatment. Donor X success rate in IVF is very good because presuming that uterus has no problem, majority of the women who come to us for donor eggs are aged women or premature ovarian failures, and or very poor embryo quality or egg quality in 2 to 3 IVF cycles. So these women have a better chances. But if the uterus is damaged or the sperm quality is very bad, then the donor cycle results also fall down. I'm with Medicover Fertility, Hyderabad, High Tech City. You can reach me out on Google, and you can find me here at High Tech. Thank you so much for a really interactive session. And I think I would look forward to any questions you could ask my colleague team, and we could be happy to answer that. Thank you so much.